Okay, this paper is the role of blood viscosity in dialysis patients. It's written by Dr. Dr Sloop over here. He was a friend of mine. He died recently. I've been going back through some of his papers. This guy deserves a Nobel Prize for figuring out the details of atherothrombosis theory, meaning that atherosclerosis is a blood clot. It's the big theory explanation of atherosclerosis that puts everything else together. Okay, it was actually first proposed in the 1800s by a famous pathologist named Rokitansky, and it's been around a long time, but it was displaced in the mid-1900s by, cholesterol theory, so to speak. But in reality, cholesterol theory is really just a subset of atherothrombosis theory. So what's the point of all this? Atherosclerosis is a blood clot, okay? And now we're going to talk about the special issues of atherosclerosis and blood viscosity in a patient with kidney disease, in particular a patient that has severe end-stage kidney disease and on dialysis. And some interesting things will come out about blood viscosity and how it relates to atherosclerosis. If you're interested in atherosclerosis, you'll find this very interesting. Okay, so first point is that, atherosclerosis and dying of heart attacks used to be really rare. It wasn't even in a lot of the textbooks, before the, around the time of World War I. Okay, it started becoming a much bigger deal after that. People started eating more high-fat diets. Okay, here's an example of atherosclerotic plaque, and when you look at it carefully, you'll see there's areas of recanalization. This is characteristic of a thrombus. A clot is called a thrombus, and then what's called organization is the immune system cells come into it, and also cells to grow new blood vessels. So they'll grow blood vessels through it. You can see recanalization, for example, in an atherosclerosis clot, in a DVT, and a pulmonary embolism. Okay. And the pathologists are the ones who know best. They look at it under a microscope. This is actually a lecture by Dr. Sloop called The Importance of Measuring Blood Viscosity. I'll try to remember. I'll put a link in the description below to his lecture. You can hear him talk about it. Okay, so here is, what I'm doing is I'm showing you some background information so that when I go through the paper, everything will make sense. So what you have is a red blood cell, and it's got a negative charge on its outer surface called the Zeta potential. That negative charge is generated by sialic acids at the end of the glycoproteins, like heparan sulfates and whatnot, of the glycocalyx of the red blood cell. Okay, those are negatively charged. That's the immune system identification card. Then the glycoprotein itself, or sometimes called a glycosaminoglycan, the point is it's a heparan sulfate with tons of sulfate, negative charge. There's also cholesterol sulfates in the plasma membrane of the red blood cell. So you get this negative charge on the outer surface that's called the Zeta potential, so red blood cells repel each other. And actually you will attract to it a ion cloud. Ion means charged molecule, and you'll get a negative charge on the outer surface. So you'll get sodiums that'll be attracted right here close to it, and then you'll get chlorides attracted to that, and they keep this charge cloud around it so no other red blood cell is going to be able to bind to it. They repel each other with their negative charges and this ion cloud. If you intercalate other elements in here with lower charge density into this ion cloud, you can decrease the Zeta potential, okay, which is bad. Okay, and there's certain things that can contribute to that. Uric acid can contribute to that, as well as some protein-bound uremic toxins. Trimethylamine oxide can do that. P-cressyl sulfate can do that. These are toxins from the gut that are increased in amount in patients that have leaky gut and patients that have kidney failure. Okay, so here's two red blood cells repelling each other, but an IgM antibody has a positive charge on its outer surface, and it can stick the red blood cells together. Normally, IgG antibodies are too small to stick red blood cells together, but if the Zeta potential ion cloud is dispersed by things like trimethylamine oxide, P-cressyl sulfate, then the IgGs can start to have a bit of a overcoming the Zeta potential effect and starts making these red blood cells more prone to sticking together. And again, you don't want them sticking together, because when they stick together and that aggregates and gets bigger, it can precipitate out, form a clot. That's atherosclerosis. Okay, really, it's a clot in the blood, but when it attaches to the wall, it's atherosclerosis. Okay, here are some examples of bridging molecules. Fibrinogen, the blood clotting protein, LDL cholesterol. See, it's big enough to stick the red blood cells together, whereas HDL is smaller, and it actually kind of prevents them from sticking together. That's why it has a positive effect. Uric acid will stick them together. It has a harmful effect, increased clotting. And again, those pictures are from Dr. Sloop's lecture in his own slide. Typical red blood cell, 7 microns. Typical capillary is about 5 microns. So what that means is red blood cells normally have to deform, like they fold back on themselves to go through a capillary. They're normally very flexible. As they get older, towards their end of life age of 120 days, they become less flexible. Partly because they get glycated, partly because of that phosphatidylserine externalization from the inner leaflet to the outer leaflet of the plasma membrane with time. But they become stiffer, and that'll also increase blood viscosity, make them less able to pass through these capillaries. When you have a bridging molecule sticking them together, it's called like a stack of coins, blood sludge, or you'll call it rouleau formation. Rouleau means stack of coins in French. Okay, this is just the background information to be able to understand the paper when we go over it together. Okay, the higher the hematocrit, the higher the blood viscosity. Red blood cells are like more than 99% of the blood cells in the blood. White blood cells are only a small amount in comparison. So if you have a higher hematocrit, like let's say you have one of these Tour de France cyclists and they wanted to increase their hematocrit, the number of red blood cells they have in their blood, to give them increased endurance when climbing the hills. The pitfall is that might help them climb a hill, but when they're just laying around, now their blood is thick and it might clot, and a lot of them died of myocardial infarctions. Okay. The thicker the blood, the higher the pressure needed to pump it to the top of the brain. It's why you have blood pressure to pump blood to the top of your brain, against gravity. And if the blood is thick like a milkshake instead of like water, pressure has to go up. So when the blood is thick because of increased blood viscosity, because higher hematocrit, higher LDL cholesterol, higher chylomicrons causing blood sludge, higher triglycerides causing blood sludge, you then have to pump at a higher pressure. When you pump at a higher pressure, that blood comes up the common carotid artery and smacks against the median divider. You've got, you can take your thumb like this, and basically your thumb is the internal carotid going up into your brain through your skull. All your fingers are like the external carotid branches that go all over your face and your scalp. And the point I'm saying is when the common carotid comes up to bifurcate into the external carotid and the internal carotid, it hits against the median divider and it bounces off. The faster the velocity at which this blood is traveling, the higher the pressure and velocity, which is equivalent for our purposes at the moment, the more it's going to bounce off of here. When blood bounces off of a median divider between a bifurcation site, you'll then have turbulent flow. Excessive amounts of turbulence will activate the platelets and make them more prone to clotting. You'll also get more retrograde eddy currents. That means backwards flow. You'll see the eddy currents backwards flow right here. I'm going to show you an ultrasound in Sloop's paper showing backwards flow here. And I see it all the time. It's a normal thing to have a tiny amount of backward flow. But if the patient's hypertensive and you have an excessive amount of backward flow, that will be prone to clotting because it's very slow. The slower the flow, the more the red blood cells clot. It's the faster speed of normal blood that prevents them from clotting. But you really want, again, a Goldilocks balance. Normal, relatively fast speed has a parabolic velocity profile, red cells in the center, white blood cells outside them, plasma outside them, adjacent to the arterial lining, the endothelium. Okay, but excessive hypertension means excessive blood velocity, means excessive smack impact when it hits the divider, and that will lead to excessive turbulence activating platelets, excessive retrograde eddy currents making the blood prothrombotic when it's flowing slow. And it confuses the endothelium because it's not expecting so much turbulent flow. It's not expecting so much retrograde backward flow. It starts to shed its antithrombotic coating, its antithrombotic global glycocalyx, and now clots will form. I can tell you, I look at tons and tons of these things. Carotid artery CT angiograms, okay, CAT scan angiograms. We do multiple of these every day. Okay, and this is where you always see the clots, right here away from the median divider, because that's where you get the retrograde eddy currents, and that's where you form the clots. And then you end up in a steady state of the clot getting a little bigger, getting reabsorbed, getting a little bigger, getting reabsorbed. So that if something later down the line tips the balance towards more prothrombotic, you might form a bigger clot on there, which could then break off and embolize distally, cause a stroke, embolic stroke from the carotid bifurcation, or it could occlude the vessel, or just, grow and make it more stenotic, more narrowed, okay? All right, here's an atherosclerotic plaque, and you've got, the acute clot right here. Then you've got stem cells in the blood. This is an important point, and regular doctors, conventional medicine, don't know this. The stem cells form a neo-intima. Those stem cells are called EPCs, endothelial precursor cells, and they form a new intima, a new lining of endothelial cells on top of the clot. You can call it a neo-intima. All right. As you get older, you have less of these endothelial precursor cells. You're less able to, hide this clot, so to speak, subintimal. They also have circulating precursor cells to become fibroblasts and to become smooth muscle cells and to become something called myofibroblasts. Okay. And this is rather interesting because circulating precursor cells can form all those other cells in these atherosclerotic plaques. You can form an atherosclerotic plaque inside of a dialysis graft that's immuno-histochemically identical to one in an artery. That's highly relevant, and this explains how it can get subintimal, which is an important point. It's partially reversible. The necrotic core of dead material, swallowed up in an immune cell, macrophages can be reabsorbed. The lipid core in those macrophages, immune system cells, can be reabsorbed. Fibrous tissue, not so much. Maybe a little bit the cellular part, not the acellular part. Calcification, I haven't seen it, although some claim that it can be. I'll believe it when I see it. I've seen a lot of these plaques. Maybe that's something in the future. We'll see, but I wouldn't bet on it. The important thing is as you start eating better, you get restoration of your nitric oxide synthesis from the endothelium. Okay, typical diabetic has terrible arteries. They're often extensively calcified, severely calcified, which means they've lost their elasticity and they're at high risk to thrombose. Okay, so as a GFR, glomerular filtration rate, drops down to like 15, then the patients get put on dialysis, most typically hemodialysis, initially through a catheter and then through like a fistula or a graft in their arm typically. Okay, so a couple points here. They're saying in chronic kidney disease, you get increased phosphates in the blood, and these have an effect on the vascular smooth muscles to transform them into cells like bone-forming cells called osteoblasts. And that contributes to the excessive calcification, almost ossification, if you will, in the arteries in patients with chronic kidney disease. Okay. So here's a healthy artery, here's a diseased artery, and these vascular smooth muscle cells have been transformed to be like bone-forming cells, osteoblasts and chondroblasts, like a cartilage-forming cell as well. So that's all very bad. Okay, you don't want your arteries calcifying. You're not going to be able to deliver oxygen as effectively. And this is one of the reasons why dialysis patients tend to be so mentally slow, because their arteries are all calcified and their blood is thick. They can't deliver blood that effectively to their brains, and they're mentally slow. Their arteries are calcified. Chronic kidney disease, you get increased clotting, increased myocardial infarction, increased dementia. They're notoriously mentally slow. You get increased clots elsewhere, deep vein thrombosis in the legs, pulmonary embolism in the pulmonary artery of the chest. You get elevated clotting factors, increased factor 7 for clotting, increased blood clotting factor 8, increased fibrinogen. You get increased thromboxane A2. It's a procoagulant chemical in the blood. That's bad. It's sort of like the opposite of nitric oxide. If you're hypertensive from volume overload, you'll also get more platelet activation from that. They'll sometimes have decreased albumin, which also leads to more prothrombotic blood. Okay, so we talked about something. Here's a good paper on blood clotting and chronic kidney failure, CKD, chronic kidney disease, and venous thromboembolism. Okay, like I said, increased fibrinogen, factor 7, and factor 8, not good. Decreased antithrombin, the anti-clotting factor, so they're just kind of screwed. If they optimize their diet, like we talk about, that can help them. All right, a couple other points. Nephrotic syndrome, they lose lots of protein in the urine, the albumin. They'll compensate by having more blood lipoproteins, but those also, include cholesterol, triglycerides, LDL. Those can be more prothrombotic. You can get increased availability of thromboxane A2, which activates platelets, more prone to clotting. We talked about getting hyperphosphatemia because you can't excrete all the fiber. You're low in something called phetuin A, which helps to prevent these clotting, so it's all bad. You get more vascular calcifications. Okay, here's a picture from Dr. Sloop's lecture about atherosclerosis in a dialysis graft. And what he meant was you could form an atherosclerotic plaque inside of a graft because it's just a blood clot. You don't need anything from the wall of the vessel. You get new endothelial cells from the circulating precursor cells that align the clot. You'll get new smooth muscle cells from the circulating stem cell precursor cells to form vascular smooth muscle and fibroblast cells and even myofibroblasts. So you don't need the wall of the vessel at all. These will be identical under not only microscopic examination but under immuno-histochemistry. Okay, that's interesting. Okay, and he says in a regular atherosclerotic plaque, the old literature is wrong, that you do not get migration of the vascular smooth muscle from the media, middle layer of the arterial wall, into the plaque. Those vascular smooth muscle, those smooth muscle cells in the plaque are actually coming from precursor cells from the blood. He says that's been proven with immuno-histochemistry. Kind of interesting, huh? So the bottom line is you don't want to be prothrombotic. Okay, now here is the paper. The role of blood viscosity in dialysis patients. And all that stuff I just went through was so you could understand this paper. Written by Dr Sloop, MD, with his colleagues. Okay, dialysis typically will increase blood viscosity. You know, one of the things is you take a lot of volume off the patient, so you decrease their blood volume. Now you've concentrated their red blood cells. So you've increased their effective hematocrit, and that can lead to thrombosis right there. Dialysis patients do not do well in general. He says half of them are dead within 3 years. So being dead within 3 years, that's like the prognosis for an aggressive malignant cancer. Okay. This is a little interesting. This is a color Doppler of the carotid artery. And what you're seeing here is, you notice the red is going to be high flow in this direction going down. The blue is going to be flow in the other direction, and the dark blue is slow flow. So this is slow flow in the opposite direction. That is the color Doppler equivalent of the diagram I just showed you for retrograde eddy currents. When you hit the bifurcation of the common carotid into the internal and external carotid. So here's the retrograde flow. Okay, these are just red blood cells starting to aggregate and to form a rouleau formation. Blood viscosity increases exponentially as shear rate decreases. Shear rate, just think of that as velocity, as the blood flow slows down. Yeah, we know about that because it's a non-Newtonian fluid, meaning that the more stasis there is, the more it aggregates. Okay. I think that's the key potential for this page. Okay, over here was just from this, that last big clot I showed you was from Sloop's lecture. This is just from the paper showing you the same thing, but it's, you know, in black and white, unfortunately. This is just showing you the same thing I alluded to earlier with regard to the ion cloud around the Zeta potential. Let's see what else on here is a little interesting. The average hematocrit of the dialysis patients was 34, meaning their average hemoglobin is a third of that, about 11. Okay, so they're anemic. And what he says is the cause of anemia, a chronic disease, is that the body's compensating. It's trying to lower its blood viscosity because it's aware of that, and that's to protect them from hyperthrombosis and from hypertension and from increased thrombosis. Having thick blood predisposes to clotting. If a clot persists long enough, it'll undergo remodeling called organization. That's what he meant by atherosclerosis of blood clot, and it'll look like granulation tissue. Okay, that's worth knowing too. It'll look like granulation tissue as a blood clot, becoming organized. You can get it in the Dacron grafts. Okay, we talked about that. You get differentiation of circulating stem cells into the endothelial cells, forming a neo-intima, into myofibroblasts and fibroblasts. They are morphologically and immunohistochemically indistinguishable from atherosclerotic plaques in native arteries. So that's a big statement. That's explaining where the different parts of the atherosclerotic plaque come from. And I can guarantee you, even recent books from big name universities, they do not have this information. Sloop is 10 times better than the textbooks on atherosclerosis. I did a fellowship at Harvard with the emphasis in vascular disease and imaging-guided surgery, balloon angioplasty, stenting, all that stuff back in the 1990s. Okay? And none of the books had any of this information. None of us knew about this. None of us, the vascular surgeons, the cardiothoracic surgeons, and the invasive imaging-guided surgeon, interventional radiologists, none of us knew any of this stuff. Okay, then when I started reading all this stuff, I read Sloop's book, and then I actually got to meet him, and we became friends, and we started talking. I'm like, holy crap, he's right about everything, and he explains everything I see on all these CT angiograms and catheter angiograms and MRI angiograms. Those are called MRA, magnetic resonance angiograms. He's right. Okay, he's really the big pioneer, but nobody hears about it. His book is totally overcharged. I bought it early, right, when it first came out for a real cheap price, but to buy it nowadays is like $157. They overprice it. It's a way of putting a paywall behind it so people, keeps it away from the public. They don't want the public to know all this stuff. Okay, and he also makes the point, atherosclerosis is not an inflammatory disease. It's a thrombotic disease. He says you don't need all this inflammation stuff to initiate an atherosclerotic plaque. Okay, that's a key point. And that's also why Esselstyn could cure it by preventing hyperlipidemia, which makes the blood prothrombotic. Okay, you didn't need to give an antibiotic. That's why he was able to prevent a recurrent thrombotic event in 198 patients in a row, or 177 patients in a row, because that's the issue, not having the blood be prothrombotic. Okay. Thrombogenic theory, talked about it coming out of the 1800s. Let's see, what else? Anything else interesting here? The high velocity bouncing off the median divider will activate the platelets, making them prothrombotic. You also get the flow separation. Flow separation just means what we saw. With the turbulent flow, you get some retrograde eddy currents. Okay, for our purposes, that's all you need to know. Okay, here's a continuation. He talks about PBUTs, PBUTs. Okay, this is protein-bound uremic toxins, and you get an increased amount of those in the blood. So one of them is, he said you get increased trimethylamine oxide, which we know from eating meat, but you'll also get something called p-cresyl sulfate. You also get something called indole acetic acid, indoxyl sulfate you'll get as well. They're all, cardiovascular risks. Uric acid itself is also prothrombotic. If you have elevated homocysteine, that's prothrombotic. And he claims the mechanism is that these chemicals tend to disperse the zeta potential related ion cloud, thus weakening the zeta potential, making red blood cells predisposed to aggregate. And you can see how a lot of people have multiple simultaneous risk factors. They'll have leaky gut, they'll eat a high-fat meal, they're vasoconstricted from sodium, their blood's prothrombotic because they're stressed out, their blood's prothrombotic because they're drinking caffeine, their blood's prothrombotic because they're sleep deprived, their blood's prothrombotic when they're dehydrated, and you can get multiple risk factors and that can tip you over the edge. You can clot, plug up an artery, heart attack, okay? So you want to avoid these things. Okay, advanced glycation end products also make the blood more prothrombotic. Okay, so he talks about that right here, AGEs. There's dietary AGEs and there's AGEs that are intrinsic endogenous formed in the body, especially in the context of diabetes. And he says dialysis patients, right before they go for dialysis, they tend to be volume overloaded with the extra fluid that they weren't able to excrete because their kidneys aren't working. That actually prevents their blood from clotting. He says it's dangerous after they've been dialyzed. They're relatively dehydrated, and now their red blood cells are hemoconcentrated. Their hematocrit is increased because of the dehydration, and that predisposes to increased risk of clotting. So he makes the point, in his opinion, they should be checking the blood viscosity with a capillary viscometer, it's called, in the dialysis units to not dry out these patients too much and increase the risk of forming a clot and them dying. Right here, the average life expectancy of patients on dialysis in the USA is less than 3 years. Not good. That's why the Kempner diet was so wonderful, very low protein diet, to try to keep them off dialysis as long as possible. Most common causes of death in hemodialysis patients are cardiovascular disease, meaning myocardial infarction and stroke, and also infection. Okay. You can also get fluid overload, and they can get edema of their airway, and that can cause them to die as well. Increased blood viscosity decreases delivery of all metabolic substrates to tissue, meaning your oxygen, your glucose, as well as other substrates. He says you got to be real careful with erythropoietin stimulating agents to raise the hematocrit, because you raise that hematocrit, the blood's more thrombotic and predisposed to clotting. Okay. And then here's the last page of Sloop's article. Talks about hematocrit being a risk factor. You also will sometimes get an abnormal deformation of the red blood cell shape from discocyte to normal shape to being shaped like an echinocyte, having little spikes on it, if you will. That also makes the blood more viscous and decreases oxygen delivery. So a lot of things can go wrong. The smart thing if you're on dialysis is optimize your diet and stuff so that you do as much work as possible for the kidneys. You minimize the work of the kidneys, and in a sense you minimize the work of the dialysis machine, so it'll have less distortion effect on your volume status and your other parameters of blood. Let's see. Hypervolemia can lead to hypertension, congestive heart failure, pulmonary edema, and hospitalization for that. Hypovolemia, lack of volume, can lead to hypotension, underperfusion of the entire body, and prothrombotic blood. Okay, so anyways, that is Dr. Sloop's take on some of the issues related to blood viscosity, blood thickness, and blood's predisposition to clotting in dialysis patients, and why these patients are so high risk to die suddenly, and they typically are dead, half of them, within 3 years of being on dialysis. So I thought that was a very interesting paper. I hope you found that helpful.